So welcome everyone, and thank you for attending this webinar on the self-management and lung diseases. We are missing something, and I think this webinar is crucial for all of us working with patients with lung diseases, especially for people with chronic lung diseases. I am Marco Clari. I'm a research fellow in nursing at the Department of Public Health and Pediatrics at the University of Turin. And I'm also secretary of the Group 9.3 of nurses of the European Respiratory Society. I'm co-chairing this session with Jana de Brand. Jana, can you please introduce yourself?
Hi, everyone. Very lovely to see you all here on the webinar. My name is Jana de Brand, and I'm a researcher, actually a PhD student at Hasselt University in Belgium, mainly in the field of pulmonary rehabilitation. And I was a former ERS early career member representative of Assembly 9.
Well, this webinar will consist in 3 presentations and then a question and answer session that will last 15 minutes. During the presentation, you can write your question in the chat, and we will collect all the questions. And in the question and answer session, we'll try to respond as much as we can to all the questions arose from the ground. So please don't hesitate to write your questions, and we hope to respond to all the questions very soon. Lastly, I want to introduce the very first speaker, which is Dr. Carol Ann Kelly. She's a reader in respiratory care and from the UK, and I will leave the floor to her. Good luck, Carol.
Okay, thank you, Marco. I think I have the slides now. First of all, I'd like to introduce myself. I am a reader in respiratory care, but I'm also a nurse, and I'm not sure why my slides are going as such. Ali, can you help there? We seem to be going through the slides rather quickly. Ali, can you help me? I'm not clicking anything, by the way.
Yeah,
okay.
Yes, I'm returning the slides.
Okay, thank you. Sorry. Yes, I am a nurse specialist by background. Just to let you know that I have no perceived conflicts of interest to declare for this session. What I want to introduce you to, first of all, is the concept of self-management, and we'll think about what self-management means. We need to explore the benefits, challenges, and influence of self-management for both patients and healthcare professionals' points of view, and also to reflect on self-management in practice, or to enable you to reflect on self-management in practice. And also we need to identify what is missing. Thank you. Okay, Ali, I'm sorry, but I don't seem to have control of the slides. Okay, so first of all, we need to think what is self-management, and there are lots of things here. I'm going to draw on my own research that was published recently, where I explored the perceptions of both healthcare professionals and patients regarding self-management in bronchiectasis. As many of you know, bronchiectasis is a disease that's certainly increasing in prevalence, and it's quite neglected really when we think about the self-management and the care interventions that we have for patients with bronchiectasis. And you can see a similarity in these are the themes that emerge. For patients, it was learning what works for them, change in moderating behavior, and autonomy. For clinicians, they thought about it as education, information, early warning signs, and what to do. And you can see some similarities there, is certainly in the language that's used, but you can also discern the differences. And I think this really emphasised, and others, to mitigate the effects of a long-term condition and maintain a good quality of life. That's the theory, that's the ideal, but in practice what we find is there is a variety of complex and multifactorial interventions that are very often evaluated and developed in very diverse patient populations. And what this leads us to is that there's doubt about what works best for whom, and also there's a lack of consensus there from both patients and clinicians. So it's quite a mixture, of what we would call a quagmire of practice out there that we need to try to delve into, to refine, and to actually learn from and identify what is the best way forward. Next slide, please. So what are the benefits to self-management? Again, drawing on my own research, which explored patients' and clinicians' perceptions of self-management in bronchiectasis. For patients, they very much saw it as a way to treat and prevent exacerbations, control anxiety. And for clinicians, they saw it as a way of empowering patients to think about clinical outcomes and the benefits in those terms, and also the economic benefits. Next slide, please. And I think importantly there, it's worth thinking about those differences between anxiety and the economic benefits that the clinicians saw. When we think about the barriers, again, we have differences here, and these differences seem to be more profound now. For patients, barriers to self-management, they found it time-consuming, and this is something we don't often think about as clinicians. We think self-management is something that patients want to engage in and that they're eager and keen to engage in. But often they're quite resistant, because self-management means that the disease becomes an everyday part of their lives, whereas they want to live their lives as best they can and to work with the disease. It's also, they see it as a lack of access to clinicians, and they see it as a proxy and a way of healthcare services being made available to them as a replacement for clinicians. And this isn't always a good way to look at it. They also see one of the major barriers is their outlook on life and their mood. And if they're feeling depressed and down, this can be quite a significant problem for them, and it really doesn't enable them to engage with self-management practices. And clinicians saw these patient factors as significant too, in the way that patients need to be engaging, need to be willing to contribute to the self-management program. Lack of tools and resources was also a major barrier for self-management for clinicians, and sometimes using a bit of a make-do approach, and using resources that are perhaps designed for COPD patients and then trying to transfer them to bronchiectasis patients, which is far from ideal practice. Thank you. Next slide, please. So what can influence self-management? From patients' perspective, they really value peer support and social support. They valued the knowledge of clinicians, so they don't see it as a substitute. They really see it as partnership working, a way of working together to get the best and to enable them to live the best lives they can. They want it to be easy to access. They don't want it to be something that's quite distinct from their everyday lives. They want it there and to be able to be accessible. And they also valued psychological services when they were provided. For clinicians, again, it's the characteristics of patients and the clinicians themselves, particularly in relation to the knowledge, skills, and education. And when we think about any self-management with patients, it's really important that we consider the knowledge and skills of the clinicians, because if they don't know or understand the disease itself, then it's really unfair that they're the ones that are trying to teach and to coach patients. Next slide, please. So self-management in practice, I've decided to look at the evidence, but there are so many clinical trials out there now. There is such an abundance of evidence available that it's really hard to try and bring all this together. So what I did was I went on to the airways section of the previous slides still, sorry, the airways section of Cochrane. And what I found was within airways, there's actually an abundance of systematic reviews that have brought all this together. We've got in total 17 reviews on asthma, 4 on COPD, 1 on cystic fibrosis, and 1 on bronchiectasis. And whilst there is some evidence there that self-management interventions may improve quality of life and reduce burden on healthcare services, especially in asthma and COPD, other caveats kept coming through, like insufficient evidence, inconclusive, weak evidence, and it referred time and time again to the heterogeneity of studies that are included in these reviews. Next slide, please. But nonetheless, we have to remember that clinical guidelines recommend self-management for a lot of our chronic respiratory diseases, and that's important, that although the evidence is weaker than we would like, nonetheless they are recommended, particularly the use of action management plans. Next slide, please. So that brings us to consider self-management in practice. And in order to think about self-management in everyday practice, we need to think about the need to explore and mediate clinician and patient-centered goals. Clinicians very often want different things than patients, and we need to talk to our patients to understand that. Can you go back to the previous slide, please? Apologies for this. I'm not sure why I can't get control of the slides. To have that partnership working, patient activation is very important as well. Patient activation is about the knowledge and the confidence and the ability for patients with a chronic illness to actually self-management. And there are tools we can now use to measure that. And there's a reference there that does it will offer a tool to you that is very commonly used now in both research and practice. We need to think about the education of the healthcare professionals, as I've already suggested, and this includes behaviour change techniques, because it's not just about didactic teaching, giving the information to the patients, but it's about helping the patients, enabling the patients to change their behaviour if that's necessary. The role of the multidisciplinary team shouldn't be underestimated, and we've got a very wide multidisciplinary team in respiratory care, and I think we should use that and value the roles of each of those. The format of consultations, resources and tools is important, and we need to think that, you know, basically one size doesn't fit all, and while some patients want a written format, others might be quite happy to go online and access something on the web. It has to be different for everybody. Treatment burden is quite important, and again we referred to time consuming before for patients, and I've given you a reference there. This was a self-management intervention that was published last year for bronchiectasis patients, which included a 48-page self-management action plan. I mean, 48 pages is just a tremendous amount, and needless to say, there was 50% attrition in this intervention. So we really need to consider the burden on patients as we design these things. Next slide, please. Okay, so thinking about patients and how we include patients, because that's what's going to enable us to consider things like treatment burden in advance. We need to think about who we include in self-management programs. Patients have to be at the center of this. It has to be about them. It has to be about their goals in order for the intervention to work and to mean anything. We also need to consider the possibility of including carers, especially if that carer is a main social contact for the patient, perhaps a spouse or a parent of a child. We need to consider that the tools must be simple, easy to use, and appropriate for the disease that they're meant to be for, that's relevant to that patient. And we need to think about alternative formats for that material that's presented online, in written format, in a style that suits the patient. We also need to think about the patient's health literacy and their ability to read and write, and the languages, of course, that we're using these resources for, and also appropriate timing. So when do we do this? Is it at diagnosis that we instigate self-management practice, or is it at another point within the disease trajectory? We shouldn't see self-management as a clinical substitute. It really is about partnership work, and it's about bringing clinicians and clinicians and patients together for common goals, to identify common goals. And it's about increasing confidence and autonomy for all patients, if the patient wants it. Next slide, please. So thinking about the patient's perspective, which we're trying to integrate now, and this is a paper that was published recently, which focused on COPD. And the summary here was what mattered to patients was about meaning, purpose, and relationships beyond immediate medical needs, and underlines the need for patient-centered holistic approaches to care and support. What this is asking for really is we need to demedicalize the care that we offer to patients. We need to use shared language, and we need to identify what's important to patients and work with patients to identify those goals and interventions. Next slide, please. So the patient's perspective from a bronchiectasis point of view, again, it's about what's missing. You know, it's a very heterogeneous disease. patients have highly individual symptoms and impact, and many current treatments do not fully capture the burden of the disease. So it really is about having things that are available that we can make bespoke to the patient. Next slide, please. This is just a quote from a patient with COPD who wrote in the BMJ fairly recently that alluded to the fact that when she reads research papers about COPD, she finds it funny that how every study assumes that we've had a continuous relationship with our primary and specialist teams, or that we've all received the same level of input from healthcare professionals and the same pattern of interventions. Next slide, please. But the reality is that often different teams and specialists don't even talk to each other, let alone us, the patient. If we accept that COPD is a multivariable condition, then surely we need to look at the multivariable lifestyles of patients and the skills they have to manage their condition. So again, it brings us back to this patient-centeredness, the patient at the very core of everything we do with regards to self-management. Next slide, please. So how can we involve the patient? Let's think about that. Next slide. So, I mean, I was very privileged recently to attend the European Lung Foundation patient conference for bronchiectasis. There's 826 people attended the conference, 60 countries, and there was over 500 questions submitted, which really shows us that there's an appetite for this partnership work, and that people really do want to work together, and many clinicians want to involve patients more. Next slide, please. One of the problems that we can come across when we're trying to involve patients and to try and discern the value of that involvement of patients is how can we measure this, especially in a research setting, but also in a practice setting as well. And what we've seen with measurements is an evolution. Next slide, please. Or these are points that you can just click on for me, thank you. Generic patient satisfaction is how it all started, but very often these are subjective, and the viability is not robust enough for many research studies. So we need to think about condition-specific patient experience scales, of which there are several, and again designed to the condition that the patient has. PROMs are becoming more prominent in research. These are patient reported outcome measures, so particularly looking at the patient perspective, and the COPD assessment test, the CAT test, is a good example of this. Next, please. PREMS is another way that you've seen these tools develop, these measures development. PREMS is patient reported experience measures. So this is more than just satisfaction or outcomes. Next point, please. And it really starts to explore how the patient subjectively feels about the condition and the care that they're receiving. And that's really important when we're trying to involve patients. Next slide, please. One of the initiatives that's going at the moment is to try and to enable us to synthesize evidence and make the evidence more robust, is to develop core outcome sets for use and effectiveness trials. This isn't about making sure that everybody uses the same outcome set, but it's about identifying a minimum outcome set that will always be used. And researchers can then experiment and still try to incorporate other outcome measures, but as a minimum, there should be this core set that's utilized. Next slide, please. This is really relevant because it can involve patients, and it's a consensus method that's developed, and getting that input from the expertise from patients, carers and healthcare professionals really makes these outcome sets very valuable and very transferable in research settings. Next slide, please. So what is missing? Back to the original question of the talk. I think what is missing at the moment is that the evidence, it's there, it's growing, there's an abundance of it, but it really needs to start to focus on what works for whom and in what circumstances more. Can you go back to the last slide, please? Sorry, last slide, please. Just to sum up, really, and the core outcome measures, we need to think about the heterogeneity of research design. We also need to think about individuals' needs, and particularly socioeconomic inequalities that need to be addressed in order to engage patients with self-management. It has to be a holistic approach. This includes the physical, psychological, social, and emotional. And I know that Karen's going to share much more insight into that way of thinking with you all. And it's about shared decision making that includes everybody. So thank you very much for listening. Apologies for the slides, but I will be happy to take questions at the end. Thank you.
Thank you so much, Carol. And your presentation was great and very inspiring. I'm now introducing you Dr. Karen Heslop Marshall from the UK as well. And she's trying to help us to understand the self-management using the cognitive behavioral therapy and how it could be useful for lung disease patients. Please, Karen.
Thank you.
Karen, I will give you the remote control. I will try this one. I think some mouse was doing interference. Maybe we'll try.
Okay. Oh. Okay. So I just like to say my conflicts of interest. There you go. I received a large grant from the National Institute for Health Research to do a PhD fellowship for CBT and COPD. I have received honorariums for doing presentations about CBT, and I am a company director of a company that provides training for CBT. So what I'd like to talk about today is just the vicious cycle of breathlessness. I'm only talking for 10 minutes, so it's very brief. Findings on a systematic review and meta-analysis about self-management in COPD, and understanding what CBT is and how it might be useful for self-management. So we all know, for people who are working with people with respiratory problems, particularly COPD, that there is a vicious cycle of breathlessness. And we can see from this vicious cycle here that it is a combination of physical and psychological problems. So usually a trigger such as exertion might bring on physical symptoms such as breathlessness. Patients may become very apprehensive about getting breathless. That may lead to anxiety, and they may avoid things and become depressed. They may have safety behaviours such as overuse of medication, not go into pulmonary rehabilitation because they feel that it's not for them and don't feel safe there. And then the circle goes on, so deconditioning occurs as well. So we've been looking at self-management from a COPD perspective, and we did a systematic review and meta-analysis some time ago, and we pulled out lots of reviews and the interventions that they used, and we grouped them into 3 categories. One was addressing physical symptoms, such as take your antibiotics and steroids. The other one was physical activity, and the third one was mental health. So we looked at all these studies, pulled out the data and analysed the data. And what we found was that patients using self-management interventions that targeted mental health alongside physical management, such as take your antibiotics and steroids, had a better improvement in health-related quality of life and fewer emergency department visits. And that makes sense, really, that if you address mental health, it can help people with their self-management, so they may not end up in A&E or being admitted. So we've been using cognitive behavioural therapy now in Newcastle for quite a number of years. And so I started this in 2002 and found that it was so useful for my patients because I could help with physical symptoms, but I had no expertise in the psychological well-being. So I did this course in cognitive behavioural therapy, and cognitive relates to what our patients think, their images, their dreams, their memories. Behaviour is what a patient chooses to do or not choose to do. So they may choose to stop smoking, or they may choose not to go to pulmonary rehabilitation. So CBT helps you look at what patients are thinking and doing and seeing if we can tweak this in some way that might be more helpful to them. Therapy is just a method of treating a problem. And the key thing is, it's not the event that's important, it's what we think about it. So CBT isn't trying to improve their lung function, it's looking at how people manage to cope with their illness, manage to cope with their breathlessness, and have a better quality of life. So the key thing that I do is when I'm with patients is find out from them. They are the experts in their experience. So I like to find out from the patient what exactly is their main difficulties. And usually it's shortness of breath. So this is one of my favorite techniques where I would put shortness of breath in the middle and just ask the patient, tell me what makes you breathless. And find out, and patients really like this because it's something you are really trying to understand it from their perspective. So they may say, I've got my COPD, and if I exert myself, if I walk, I get breathless, and in the weather, if it's cold. So you ask patients what actually is impacting on their breathlessness, and then you can work out what to do about it. So most of these things on here that the patients identify aren't treated with drugs in COPD. Drugs have a limited benefit. It's the non-pharmacological treatments that can help. So this is a really good way of looking at ways to address things like stress and anxiety, which most people think, when I can't breathe, I think I'm going to die. We can work with that, and that's what CBT does. So it does help you look more in depth at patients' difficulties, what they're doing, what they're thinking, and look for potential ways to change that. So that the whole benefit to me is that the CBT model helps you address their physical symptoms, their psychological well-being, and perhaps look at their social well-being, which is also important. So we developed this brief intervention delivered by respiratory nurses, and I think this is really key because you have an understanding of the patient's respiratory problems as well as their psychological issues. So patients were recruited and randomized to either the group on the left, which there was 4 nurses delivered a very brief intervention of CBT, and they had some self-help leaflets, compared to just the self-help leaflets alone. And we followed patients up at 3 months, 6 months, and 12 months. And what we find, if you look at the graph on the left, you can see the hospital anxiety and depression scores, which were over 8, which indicates symptoms. The scores were significantly high. They came down. This is the CBT group at 12 months, 3, 6, and 12 months. And the dotted line is the leaflet group. So they both improved. But the CBT group, with this very brief, cheap intervention, significantly improved symptoms of anxiety and made the patients feel better. Now, interestingly, most people are not really bothered about how patients feel. They're just interested in hospital admissions. I don't know about Europe, but here we're just interested in people's hospital admissions. That's what costs a lot of money. So luckily I collected the EQ5D data, and that you're able to work out hospital admission uses in emergency department. So this figure on the right shows, it's called a cost effectiveness plane. I didn't understand much about it, but I've learned over the years what this means. So if these are all the patients in my study, and it was 279, so the biggest study in the world to date. If some dots were in this line, this means that the intervention was very expensive and useless. So we don't want to have an intervention like that. If it's in this bottom corner, which most of my patients were in, this means the intervention was very cheap and very effective. So this is one of the only studies in the world at this level that has shown that respiratory nurses with some training in CBT skills and techniques can actually make a difference for admissions to patients. And of course, and we know that reducing the admission has a better benefit on patient and mortality. So really, I just wanted to say that CBT is a potential way to help people address self-management, to look at things in a holistic way, to address their physical symptoms and the psychological symptoms, and hopefully have a better quality of life, reduce psychological difficulties, and reduce healthcare utilisation. And obviously, I'm a big fan, but I'm very biased that CBT skills are just so valuable for people working with anybody with a respiratory problem. It can work across the board. So I think we're having a poll here. So I don't know whether you can do this. Oh, we're not having a poll? No, I'd just like to find out from the participants, do you think addressing psychological well-being is important or not? Moment of truth. How are we doing? So can we have the results? Yeah, no, 1%. Oh dear. Right, okay, well, thank you very much. At least 99% of you think it's important, so that's amazing. Thank you.
Thank you, Karen, for this very passionate talk, and I think you convinced 99% of the public. Really good job. So we will proceed now to the last speaker of today. So welcome Steve Jones. He's the president of the European Pulmonary Fibrosis Federation, and he's also based in the United Kingdom. And Steve will guide us through what is missing in peer support in self-management. So Steve, please, the floor is yours.
Thank you very much indeed, Jana. And you see, I've stolen from Carol the what is missing at the end of the title of my talk. I'm also the chair of Action for Pulmonary Fibrosis in the UK, and I was an IPF, idiopathic pulmonary fibrosis patient. I lived with IPF for 8 years before getting a lung transplant 5 years ago. So I'll be talking both from my own personal experience, but also from experience of all those patients who I've been working with for the last few years in patient advocacy. Okay, let's see if the challenge works. I don't seem to be able to advance it. Ah, yes. Did you do that or did I? Okay, anyway. Okay, so I've got no perceived or real conflicts of interest for this presentation. Next slide, please. Okay, I want to talk about 4 things very briefly in my 10 minutes. Why peer support is important in self-management, a brief word on progressive pulmonary fibrosis, think a little bit about ways to access peer support, and to ask the question, what is missing? The definition I always think of with self-management in plain language is a way for people living with long-term chronic conditions to create a more sustainable way of living with that healthcare problem that they have. So for me, as an idiopathic pulmonary fibrosis patient, it was very much around managing breathlessness, managing the side effects of medications, and managing a debilitating cough. For people to be good, get better at self-management, we need to give them knowledge about their disease and the medications and non-pharmacological treatments that they can have. We need to build their skills and build their confidence to manage their own healthcare. The concept dates, I think, as Carol may have mentioned, from the 1960s, but it's now really mainstreamed in health services across Europe. But I'm not sure, as we've heard today, that it's mainstreamed that effectively. For me, as we heard it also from Carol, the patient must be the center of the whole system. As a patient, I looked up to the hospital specialized services in interstitial lung disease. I was very fortunate. I was being treated at a specialist hospital. I had a telephone link to a nurse that I could talk at in office hours, 5 days a week. It was a pretty safe and secure feeling, particularly when it comes to managing side effects of medications. There was somebody there to help. Similarly, for other things like my cough, if I got a chest infection, I could go to my primary care provider. Again, relatively good, and I could go to community care for the oxygen nurse and for other requirements I had. So there's very much about that relationship, as was said earlier, being a genuine partnership. I'm fortunate, I live in a part of the UK where that worked extremely well. That isn't the case throughout our country, and it's certainly not the case throughout Europe, as we know from talking to patients across Europe. But for the patient, what I found equally important for that to the support from specialists and from the healthcare system is the support I received from my peers. I was very fortunate, well, crazy really, I didn't even notice that there was a support group for the first few years living with my disease. But once I did, I went to the support group, I joined it, I reluctantly went, I was dragged there by my wife, but I came out with a spring in my step. Because here, from a feeling of isolation, I found myself in a room full of people who spoke my language, people who understood what it was to live with this disease, and who could, had information and knowledge that I didn't have about how to manage the condition, to self-manage. Many groups also have Facebook and other social media groups where you can get help. And Action for Pulmonary Fibrosis in the UK, we run 2 types of telephone helplines. We run one with an ILD specialist nurse, a retired nurse who answers calls for us, which is really important when, I think particularly often with the end of life questions that carers phone up about concerning loved ones. But we also have a buddying system where we have a number of experienced patients and carers who talk on a regular basis to groups of people who are living very isolated lives with the disease. So we outreach to people who perhaps, we're an older population, generally speaking, with pulmonary fibrosis. We reach out to people who are older and aren't internet connected. So that's very important as well. So for me and for patients who, what we do through our support groups and other mechanisms is to really build that peer support for patients when they need it. As progressive pulmonary fibrosis is a form of lung disease with, if we take the WHO definition of Europe, which is much wider than just the European Union, 500,000 people in that wider definition of Europe live with the disease. It's an incurable lung disease. It's fatal. People generally die within 3 to 5 years of diagnosis. IPF is the most common form of it, but we have other things like bird keeper's lung, farmer's lung, which is chronic hypersensitivity pneumonitis, CHP. We have autoimmune diseases like rheumatoid arthritis, ILD, and we have occupational diseases like asbestosis. All of these affect the interstitial tissue in the lungs and are a progressive pulmonary fibrosis. It's characterized by increasing breathlessness, debilitating and worsening cough, fatigue, and as you get well advanced in the disease, which is only a matter of a few years generally, dependence on supplementary oxygen, increasing isolation and disability, and sadly death by either respiratory failure or a related respiratory condition. So when you start on the pathway, it's much like a cancer without remission, because for people with pulmonary fibrosis, there is no remission except if you're one of the 1% of people like me who are lucky enough to have received a lung transplant. The problems pulmonary fibrosis patients face are isolation and lack of reliable information. You feel really isolated because you go to your GP surgery, you're the primary healthcare provider. There's probably 2 or 3 other patients on the books of that GP, even if it's a big practice. You lack reliable information. You're told you're diagnosed and given the bad news by the consultant. The consultant says you've got 3 to 5 years to live. If you're lucky, there's a nurse working with him or her and who's able to give you a bit more information. But then you go home and you look at the internet and you get absolutely frantically scared by what you read there. It's at that stage that patients need peer supporters to come in and explain to them what the journey's like, to give them confidence that just because you have been diagnosed today with this disease, it doesn't mean you can't do today what you did yesterday. Your life is going to change, but it can be a good life still for the years that you've got left. It's managing the problems of breathlessness, as I said, the side effects of drugs, the chronic cough, oxygen choice and equipment. I don't know. Oxygen equipment seems to be stuck in the 19th century. It's heavy, it's difficult to use. If I can have a remote control for my television, why can't I have a remote control for my oxygen cylinder? Very simple things. It's something which has been ignored. It's a high patient priority, but the system seems to have ignored it. And we have problem accessing services, pulmonary rehabilitation, mental health services, and end-of-life care. So where can you find peer support? Well, here are some of the logos in the top left of the partner organizations, the members of the European Pulmonary Fibrosis Federation. We are 21, I think it's now 23 actually, member organizations across 17 countries in Europe. It's amazing the diversity we have within the group. National patient organizations exist in many of the countries. In the larger, older established members of the EU, if you like, including the UK, they're pretty well developed. In some other countries in Europe, there's a long way to go in strengthening the patient organizations. National patient organizations can provide reliable information from the website and social media. So if healthcare professionals on diagnosis and during clinic visits can just say to patients, here's a reliable source of information to go to, here's a source of help if you need it, which is outside the healthcare system, that would be so good. And as I said before, we have most of these patient organizations run or are part of some kind of patient telephone support line. And as I said, patient support groups like this one here in Scotland reduce isolation. They provide information and advice and empowerment and mutual support. And so what is missing at the end? I think we need three things. We need greater recognition by nurses, doctors, and other healthcare professionals of the value of peer support. About, the word demedicalize was used earlier. It's a bit like that, demedicalizing sources of support and help. Peer support often can be more valuable at certain times, even than a healthcare professional support, because some of us have already had the message from healthcare professionals. We can pass it on in a way that's understandable and reassuring sometimes, and we can repeat it because we're there more often. It's important to refer at diagnosis to patient support groups where they exist in your area. So if a patient's just been diagnosed with ILD, refer to a pulmonary fibrosis support group. If they're another respiratory patient, there are other groups. In the UK, for example, the British Lung Foundation runs Breathe Easy groups, which cover all respiratory conditions. Really important that HCPs know what's going on in their area and can refer patients and can help those patient support groups in contacting other people with the disease who may be isolated. We need to educate a cadre of patient advocates in both the disease and in the treatments who are able to support patients better. Some of these people always emerge. We do our best to bring them on. We need to be more systematic about how we do that. And especially in those countries where patient organizations are just starting off. And we've really got to tackle inequality in access within countries and between countries. The hub and spoke methods that we have in so many things with specialist centers and other general hospitals around them don't really work very well for patients. Patients at the specialist center get a much higher quality of care than patients, generally speaking, in district general hospitals. And I've checked this in a number of countries in Europe, and it seems to be very much the same. And we desperately need more specialist nurses in all our disciplines. I think the UK is reasonably well off now with specialist nurses for interstitial lung disease. Big other countries, I believe Germany, the last time I asked, had only one specialist nurse. I hope somebody tonight tells me I'm wrong, but there's a lot more to do. So finally, sorry, I've gone the wrong way. Finally, if you'd like to, free of charge, you'd be very welcome to come to the first ever European Pulmonary Fibrosis Patient Summit in this year, 2021. We had planned to hold it last year, but had to postpone it because of COVID. It's on the afternoons of the 23rd, 24th, and 25th of April. If you go to euipff.org, you'll find details of how you can register. You have to register this week, by the weekend, by the 20th, in order to be able to come. But you'll be very welcome. Come for 1 or 2 sessions. There'll be many nursing topics covered as well, or stay for the whole event. You'll be very welcome. Thank you very much.
Thank you, Steve, and very interesting, this patient summit. We are perfectly within time, so I'm going to pass the word to Marco again, and he's going to guide us through the question and answer session.
Thank you, Jana. Well, first of all, I want to reassure all the participants that the presentation will be on the ERS website, so you will find all the presentations after the webinar. And then I will ask some questions to the presenters. Well, the first one is for Carol, is from Nicola Roberts. Do you think healthcare professionals need some additional training support to implement self-management training into their routine practice?
Absolutely, I agree with that. Thank you for the question, Nicola. I think, you know, as I said before, the information we give to patients needs to be reliable and it needs to be accurate. And our relationship with patients needs to be built on trust. And if we don't have the education and we don't have the skills and the knowledge ourselves to enable patients to learn about their condition and to self-manage, then we're not going to be able to build that trust. And there is something that happens in practice a lot. I know a lot of you will relate to this, is this idea of mixed messages where different people give different advice, different healthcare professionals. So the nurse says one thing, but the doctor says another thing. And that can be very confusing for patients. And it can also lead to inappropriate advice and inappropriate action. So I think education of our healthcare professionals, and I know that's something that the ERS nurses group is really interested in as well, I think is absolutely key to this. We have to have some basic knowledge and skills ourselves in order to share with our patients. Thank you.
Thank you, Carol. I just want to ask you a question. Literature about healthcare failure and other chronic disease now talk about self-care, no more on self-management. What do you think about this?
I think it's about language. It's about use of language. I think effectively they both mean the same thing. I suppose self-care, it could almost be a preventative model where, you know, we're looking at healthy lifestyle, making sure we have good diet, exercise, and we're keeping ourselves fit and well, psychologically as well as physically. Whereas self-management is about a disease. If we have a disease, then it does tend to be that we have to manage it in some way to enable patients to live with the disease and ensure that it doesn't dominate them. So there is, I think they're two different terms. I think they can be interchangeable, but I think they're both quite distinct as well.
Thank you. Another question from the floor is from Daniel Schürmans. Sorry for the bad German pronunciation, I think. Well, education and information to empower a patient is highly dependent on appropriate word usage. I know of few patients who do anything other than what they have understood. Unfortunately, this may be far from what we have said. What do you think, Carol?
I agree completely. And I think, again, that comes back to setting patient-centered goals. You know, find out what the patient wants to do, you know, what's important to them, because it's going to be individual. For some patients, they might want to play football with a grandchild. To other patients, they may want to go to school or to work normally. It depends on their age. Find out what they want to do, and then try to find ways, negotiate ways of working with that patient to find interventions, to identify things that are going to help them to do that goal that they wanted. If we focus on the patient's needs rather than, for us, our goal might be that the patient is less breathless. Well, obviously that's the same goal for the patient, but it doesn't always manifest like that. It is that the patient wants to be able to carry his own shopping and not rely on a trolley. You know, there are different. So find out what the goal is, translate it into the patient's language, and you may find that they're more willing and able to work with you.
Can I just come in there, Marco? I mean, I think thanks. I agree very much with Carol. There's a real point, though, about language and the level of language with the readability of what we write. I recently looked at a number of healthcare professionals' instructions to patients or descriptions of disease. Most of them, you need a pre-university or sometimes post-university level of education to read them and understand them. You know, we've got to write. If you think of the popular newspapers in the UK, they write to an 8-year-old's reading age. So we've really got to be writing in similar, plain, clear language, lots of diagrams, easy to understand, if we really want to make sure we get our message across to all patients.
Well, Karen, there are some questions for you as well. The first one I want you to read is, how do you deal with the patient who is not interested to talk about their problem? And also, I think it's connected with, do you have any good practical suggestions about how to implement cognitive behavioral therapy or self-management program while we are visiting our patients?
Okay. Well, the way to work with patients who don't really want to talk about their problems is to focus on what really is their problem. And usually it's breathlessness, and people do want help with breathlessness. So it's a win-win for you and the patient. So for me, I always start off with their breathlessness, if that's their main issue. And then we can explore the reasons why they're breathless, whether it's physical or psychological. And usually people are more than happy because they can see your goal is their goal. And it's a win-win situation. So there are lots of, I mean, I can't in a few sentences explain how to do it. You know, we do have an online course for people who want to do it. They can email me. But really, it's, you know, I see patients, I do a breathlessness CBT clinic. I see patients for the first time for 45 minutes and then for 15-minute follow-ups, and I would see patients on average 3 times. So the first time you see people is understanding what their main difficulties are, such as doing the breathlessness spider diagram, and then working out what interventions might help. And I've also got a top tips leaflet on breathlessness. If anybody wants it, I can email it to you, and you're more than welcome to use it. And that's a way of helping people understand all the techniques that might help, whether it's psychological or physical. They're all in one leaflet. They're all about breathlessness, and that's what people are interested in having help with.
Well, there is another question for you. It's from John King. And do you think that basic cognitive behavioral therapy should be part of the nurse training? But I want to add that every healthcare professional training maybe is useful for lots of LTC. And in particular, cognitive behavioral therapy for stop smoking, for example, could be an option.
Absolutely. It should be a core skill for all healthcare professionals. And it is used in asthma. I saw a question about is it used in asthma? CBT is used in asthma. There is research about that, and also all kinds of conditions, long-term conditions. It's just perfect because the model, it just looks at the whole person and the difficulties they're having. And I think having respiratory nurses do it makes it far more effective because you understand the difficulties and the things that patients may be doing that might not be very, very helpful to them, and be able to explore that with them. So yes, it should be in pre-registration training, without a doubt.
Thank you, Karen. And I just want to try to merge some questions, and I think that Steve will be the perfect presenter to ask to these questions. It's there were many questions about how patients dealt with the pandemic and their availability of self-management, because many patients didn't attend to the visits, or it was a little bit for them, it was anxious to go to the hospital or to their physician during the pandemic. So what kind of self-management did you do? Or maybe some patients could have increased their self-management due to the small amount of opportunities to go to the physicians or to the hospital.
I mean, it was an extremely difficult time it's been for the last year. I mean, a number of patients, not only many patients were reluctant, I was reluctant to go for my transplant checkups as well to the hospital for a period of time during the peaks. A lot of patients the clinics also were closed. Lung patients often need to have pulmonary function tests as part of their general monitoring, IPF patients in particular are really conscious of what their FVC is and how it's declining. And they really want to have that regularly as they always used to do. And because it's an aerosol, well, they're now telling me it's not an aerosol generating procedure, but it certainly did reduce the ability. Hospitals are not offering it nearly as much. We have many patients who really need those tests who haven't had them for over a year now. So it was really difficult for people. People felt very isolated. They had to stay at home. We found, as the main charity involved with interstitial lung disease in the UK, we'd get a whole raft of more visits to our website for information. We put an information hub on the website for everything to do with COVID that people needed to know. And we set up, as I said previously, we had a nurse helpline, which is great, and we kept going obviously with that, and we still do, but we supplemented it with peer support helplines so that people could just have that comfort of somebody to speak to when they have a real problem. They could be helped to sort out that problem by a peer who, if they don't have the information themselves, they can find out the information from other people in the organization. So we did the best we could as a charity. What really worries me is the number of patients who didn't come to us, didn't know about us, didn't know about what was available locally. Imagine if you were a poor woman, a PF patient with mobility problems, living on the 17th floor of a high-rise block. What do you do? How do you get out? You're scared to go in the lift in case you meet somebody else with COVID. It's just really petrifying. And I think we, as a society, I don't think we've done a nearly good enough job at thinking about the most disadvantaged during the COVID. Sorry, not a very good answer to your question, Marco. I'm sorry, but.
Never mind. It was a very good answer, really. Well, we had many answers from the floor, but we have no more time actually to respond to all the questions. I invite you to write directly to the various speakers. You will find their email in the presentations that will be posted on the ERS website, and I'm sure that they will be very happy to respond to you. And also Jan and I will be happy to respond to you if you have any further question that is really crucial to you after this very good webinar. Thank you very much to all. Jana?
Thank you all for joining us tonight. It was very interesting. Of the three speakers, I think it's done or not? Okay. No. It was very interesting, those three talks on self-management. I hope that a lot of people got some answers to their questions, and please reach out to the speakers. I wish you a very pleasant evening, and let's say goodbye. Thank you.
Bye, everyone. Thank you.
Bye.
Bye.
Thank you all. Bye-bye.
Thanks a lot.